Welcome to Dr. Choice's M1860 Ambulation webinar. In this webinar, we're going to discuss how to properly score and answer the M1860. Let's begin. Remember, the therapy assessment tool is in the home folder. Use this sheet and fill it out as you're assessing the patient. You can bring this back and enter that information into the 1800 therapy report. Remember that the therapy scheduler will schedule an 1800 report when an evaluation is performed. And keep in mind that there's a difference between the 1800 values and the 1900. These 1800 values are taken from the therapy assessment tool in the home, and the score is placed to the side. The scoring for the 1900s is taken from the key above, so make sure that there's no confusion when using this key and putting them under the 1800s here. Before we talk more about the 1860, there's an important point for therapists to realize. The slide that you're looking at can be confusing, but this is the way the formulas are designed in order to give value to each of these 1800s. So if you take a look at 1860 here, you will see that for ambulation, when we scored a 1, 2, or 3, there's a value of 7 points given. When we have anywhere from 0 to 13 total therapy visits. If we have 1860 scored as Chairfast or bedbound, you'll see that there's values given under 13 visits or up to 13 visits. But once we go to 14 or greater visits, ambulation is not even considered in the formulation, but it is when someone is considered Chairfast. The important point to realize with this slide is that we must score 1800s accurately, because Medicare will give value when somebody is indicated they have a considerable issue with walking. So the question is, how do we understand 1860 in relation to how Medicare views a patient's ambulation? We're going to take a quick moment to review the conventions of scoring. And the two most important aspects are, number one, that all answers should be scored before interventions. Remember, interventions can be anything from verbal cues, hands-on, or environmental setup. If you had to do any of those things to help this patient, you cannot say they were independent. Safety, safety, safety is integral to ability. The most important aspect of understanding the 1800s. When I score them with a value on 1800s, I am saying they are safe under that condition. So therefore, if I am reading an answer to the 1800s, and even under those conditions they are not safe, they're not free from risk, so therefore they're not able to be scored at that level. Therefore you would score them accordingly, maybe lower than that level, because that current scoring would make them the most safe. So that's an important aspect to remember when looking at 1800s, and in particular 1860, we will see that on a few examples. Ambulation includes the assessment of their ability to walk once standing, or if they cannot do that, how do they use a wheelchair? Those are the considerations. Keep in mind, if they have a fall risk, you must consider this in regards to the safety as it relates to ambulation. If they have a score that indicates, for example, on a tug value, that they are a fall risk, it'd be unlikely that they would be independent in these measures. You're scoring on all three surfaces. So remember, when you go to the home environment, you're looking at the level surfaces, maybe the entrance to the home, which could be grass, gravel, unlevel, managing steps or a single step or a ramp or so forth. So keep in mind, you must assess all of those environments, not just the level surface if you're in the home. So when we're considering 1860, how are we assessing it? Well, primarily through observation, as the patient is engaged in their home, going to the bathroom, across the room, maybe to the laundry room, etc. You're going to look at them on a variety of surfaces, not just the level surfaces in the home. You're going to observe the person's ability to manage steps or a single step. And keep in mind that if they're Chairfast and they're using a wheelchair, you're going to look not only on their level surface, but also on ramps and the adaptive surfaces for them to manage. This is regardless of whether you're using a power wheelchair or manual wheelchair. You're assessing their ability to use the wheelchair that they are using. So if we take a quick look at 1860, this is how Medicare has the question laid out with the answers. So we're going to go through each section and discuss them. So the first answer is 0. Are they able to walk on even uneven surfaces, manage steps, look at all the surfaces in the home? And you've told Medicare, yes, I have, and this person requires no intervention from myself. This means no verbal cues, no recommendations, nothing at all. This person is doing perfectly fine. It doesn't mean this patient is not necessarily homebound, though it could indicate this person's very high level. So we definitely have to assess the patient's tasking efforts regarding the ability for homebound status. But if you're saying somebody is 0, they do not need any therapy to address gait. Scoring a patient with a 1 is no different than 0, with exception to the fact that they have a single-handed device. This means that you've assessed their ability to walk on all surfaces with this device and do it safely. Keep in mind, a wall is not a device. A device is something that is able to be used in an open area and can be used for ambulation. Walls may be helpful, but it does indicate to you this person has a balance problem, and they clearly are not safe if they have to reach out to furniture. They should have a device, and this is something you may assess. So keep in mind, with 0 and 1, you are telling Medicare that no therapy is needed to address gait. They are perfectly fine. When we select answer 2, there are several things to consider. First off, selection of 2 indicates that this patient is safe using a two-handed device on level surfaces, and this could be a walker or crutches, 2 canes, etc. Or regardless of the device, needs intermittent supervision to be safe. So this can include someone who doesn't have a device at all when you're assessing them. Maybe they should, but again, they could use intermittent supervision. Somebody does not need to be with them all the time. Or 3, needs assistance or supervision on steps or stairs on a level surfaces to navigate. This is regardless of a device. So when you're looking at scoring somebody 2, the first thing that's important to realize, just because you see they have a walker and are ambulating with it, if you score them a 2, you've said, I don't have to give them any instructions to walk safely alone on a level surface. If you do, or have to give some assistance, then the question is, are they really safe to walk alone? Meaning 2 may not be the right answer for them, because they may always use a walker at some point. Maybe you should have scored them a 3. After the instructions and training, they may improve to a 2 where they're fine on a level surfaces, and therefore you've improved them. So don't automatically think you're going to score somebody a 2 if you see a two-handed device, unless you've assessed their assistance level. And if you're giving them assistance, then it would be unlikely they would be scored a 2. They would probably be scored a 3 in that regard. In order to score somebody a 3, you are indicating they are safe when someone is with them at all times, whether they're assisting or supervising them. So keep this in mind. This is regardless of the device. If someone should be with somebody who doesn't use a device, but should have somebody near them or helping them at all times, you can score them a 3. In that case, though, it is likely somebody should be instructed or a device should be assessed for this patient. The one thing that is also important to remember is, can I score this person a 2 or 3 if they live alone, when they don't have anybody that can supervise them? The answer is yes. The question is not asking, does somebody live with them? The question is asking, what would be the recommendation to make this patient the safest level? They should have somebody with them, or somebody should be with them intermittently. So keep in mind when you get to these questions, whether somebody's living with them or not is irrelevant. You're recommending what the safest level of scoring should be. Interestingly, when you score somebody a 3, even with constant supervision and a device, can somebody be scored less than a 3 if they're deemed unsafe? Meaning, can somebody who's ambulating but still is not safe with both of those circumstances, be considered Chairfast? Their answer is yes, and we're going to take a look at 4 and 5 in a moment. 4 and 5 indicates that a patient is Chairfast. So let's remember what Chairfast is. Chairfast means that the person, regardless of the time, can tolerate sitting upright without any adverse events. Bedfast means somebody is unable to sit up, regardless of the time, without some intolerance or adverse event occurring. So in the case of ambulation, when I consider somebody Chairfast, I need to also assess their ability to use a wheelchair on level surfaces, the ramps, etc. And 4 and 5, the difference is either they're able to do it safely independently or they're not able to. Keep in mind, though, that any type of assistance at all, verbal cues, is assistance when you're assessing this. Also, if they don't have a wheelchair, you cannot assume they could operate the wheelchair, and you would have to score them accordingly. So going back to the prior example, when we were talking about scoring somebody a 3 and can I score them a 4 even if they're ambulating? The answer is yes, because Medicare is stating that even under the conditions of somebody requiring assistance at all times with or without a device, if you deem them unsafe under that condition, what condition or what scoring would make them safest? So for example, if I have a patient walking 20 to 30 feet with a gait belt, I'm holding on fairly tightly, they're leaning heavily on the walker, maybe they're shuffling in, and they're covering some distance, but it's a bit precarious, and even with me there, they could get hurt. I should say they're really not safe. I can't score them a 3, but they're safest sitting in a chair. They're free from risk then. So in that example, I would score this person a 4 or 5, saying they're really safest Chairfast. Then I'd have to determine their ability to use a wheelchair, and if they had one, I would assess it, and if not, I would have to score them a 5, saying unable to wheel self, because I cannot assess the wheelchair at that point. The takeaway of this is, with most of these questions, you have to go ahead and assess the safety aspect, and if you don't see that the score you would likely score them would make them safe, you score them lower to the one that would put them in the condition that makes them the safest or free from risk. Number 6 is Bedfast. They're unable to ambulate or be up in a chair. Selection of 6 indicates they cannot sit up in a chair regardless of the amount of time due to some type of adverse reaction. So for example, if somebody has severe hypotension, the minute they get up they start to have a drop in blood pressure and have to lie down. Or it could be somebody who has a multiple muscle atrophy condition. If they can sit up for a period of time, then they are not considered Bedfast. M1860 can be looked at with an algorithm. The first question you ask, are they ambulatory? If not, can they be in a chair? If not, they're probably Bedfast. Are they able to be Chairfast, but do they operate a wheelchair or not? And can they do it safely? You would score 4 or 5 accordingly. But let's say they are ambulating. First off, do they have a device? If not, are they safe? Should they have a single device? Are they using a single device? Are they safe? If those answers are no, then you go down to this saying, well, should they have intermittent supervision, or do they have a two-handed device and are safe on a level surface, or do they need assistance on unlevel surfaces? If under that condition they are not safe, then I would go to 3 saying, does the condition 3 make them safe, where somebody should be with them at all times constantly? And if the answer is yes, that could be appropriate, but if not, you may even consider them Chairfast based on 4 or 5 on their ability to use a wheelchair safely. The next slide takes a look at the environment and the assistance with these scores, and as you notice, 0 and 1, there is no assistance at all, no indication really for therapy. The environment for 2 can be even surfaces and uneven surfaces, and you're using a two-handed device or one-handed device or no device at all, but you may have some level of assistance. 3 considers all surfaces as well, and this requires constant assistance at all times, probably a very high fall risk. 4 and 5 are Chairfast, and then we look at the all surfaces using the wheelchair. And Bedfast, the assistance is irrelevant in that question there. A few questions from Medicare. What if a patient does not have a walking device but is clearly not safe walking alone? The answer would be the clinician would select 3, able to walk only with supervision or assistance, unless the patient is chair-fast. 4 and 5 would depend on the ability to use a wheelchair. Another question, what if a patient does not require assistance and is able to safely ambulate with a walker in some places, but must use a cane in other areas due to space limitations, distances, etc.? The answer is a clinician will select the response that reflects the device that best supports safe ambulation on all surfaces the patient routinely encounters. For example, 2, if a walker is required for safe ambulation in the hallway, in the living room, even if there are some situations in the home where a cane provides support. If a patient scores 0 or 1, be prepared to defend the patient's homebound status. And if a patient scores 2 to 6, consult with PT or OT to improve the patient's outcomes in ambulation. What if the patient uses a wheelchair for 75% of the time and walks for 25% of the time? Because of the 50% rule, would I score them based on the wheelchair, or should they be scored based on their ambulation status? The answer is they would be scored on their ambulation status, because they do have the ability to walk, therefore you're going to assess that first. Just because they use a wheelchair does not indicate they are not able to walk. Medicare's definition of Chairfast states that the patient is unable to ambulate at all times and is confined to the wheelchair. If the patient ambulates more than taking a couple steps to do a transfer, the patient is considered ambulatory and must be graded as ambulatory. A couple other considerations. What if you have a medical restriction? That is a real inability for the patient, so therefore it's not out of choice, but it affects their ability to actually perform the motion. So a medical restriction is considered a factor when you're looking at these questions. When you're assessing the patient, do you assess them based on what you think they could do or project forward? You only assess what their current level of function can be. And if a patient is blind and a cane is used for navigation, is this acceptable as it assists the patient even though it's not for weight bearing? The answer to that is yes. It's still a device for them in order to ambulate and is considered a device for assistance. Another additional consideration is if someone scores 0, does that disqualify them from home care services? Not necessarily, though you would certainly have to scrutinize their ability to be home. But somebody could have cognitive issues, severe anxiety and fear, maybe a severe endurance limitation. So it's not an automatic disqualification from home care. But what if someone chooses not to use a device? I mean, they're unwilling. Is that a factor? The questions are only asking about their ability. So if they can use the walker but choose not to, you assess the ability to use the walker and score in that regard versus refusing. That's in difference to somebody who's terribly afraid or scared of doing something that's different. They're not willing. They have a real emotional issue that causes their inability. So again, be careful to make sure you're assessing ability, not lack of willingness. That concludes our online training for M1860. If you have any questions, be sure to contact your rehab manager, director of therapy, or your director of clinical services.